Colorectal cancer has traditionally been thought to develop via the adenoma-carcinoma sequence. Hyperplastic or serrated polyps were not thought to develop into colorectal cancer. However, in the last decade it has become clear that this view was incorrect and that the new serrated pathway may account for up to 1/3 of colorectal cancers. This important scientific insight led the British Society of Gastroenterology to commission a position statement on serrated polyps. It was felt insufficient evidence for a formal guideline existed, yet doctors needed clinical practice guidance in the interim, and this position statement would indicate the Society's thinking on this issue. A range of experts in the field were invited to form a working party with the scope including evidence that serrated lesions have premalignant potential, detection and resection of serrated lesions, surveillance strategies after detection of serrated lesions, special situations, specifically serrated polyposis syndrome, including surgery, and serrated lesions in colitis, as well as education, audit and benchmarks, and research questions. Major conclusions affecting endoscopy, pathology, surgery, and genetics were that sessile serrated lesions are precursors to colorectal cancer, and sessile serrated lesion, with or without dysplasia, is the preferred pathological descriptor. Meticulous colonoscopic white light examination is optimal for detection, and if serrated lesions are found, they should be resected. A one-off surveillance examination at 3 years is recommended for patients with a serrated lesion 10 mm or larger in size, any serrated lesion with dysplasia, and traditional serrated adenomas. Surveillance is not recommended for smaller serrated lesions unless sufficient to meet WHO criteria for serrated polyposis syndrome. Patients who have sufficient lesions to meet serrated polyposis syndrome criteria should have colonoscopic surveillance every 1 to 2 years, and a genetics referral should be considered. No recommendation was made regarding serrated lesions in colitis. Knowledge of serrated lesions will be important for trainees and practicing GI clinicians, and endoscopists may wish to benchmark themselves against a proximal serrated lesion detection rate of 5%. Nevertheless, many research questions remain to be addressed, including the role of molecular markers for serrated lesions, improving lesion detection, options for chemoprevention, and whether surveillance is clinically and cost-effective. Clinicians are strongly advised to support prospective studies that will bolster this evidence base and avoid empirical management decisions to allow formal guidelines to be developed in the future.